speaker is Dr. Laila Woc-Colburn. She is currently an associate professor, Division of Infectious Diseases, Emory University School of Medicine, United States. She is holding MD and Diploma in Tropical Medicine and Hygiene, and she's a fellow of the Infectious Disease Society of America. Dr. Colburn is going to speak to us today about the antibiotic resistance. Please, if you may start, Dr. Colburn. Thank you.
Thank you. And thank you for having me to the organizing committee of the MEGA. And thanks to Dr. Abu Dhabi and, and Dr. Hidalgo and Dr. Mandy for this opportunity. I'll share my screen. All right, I'm Dr. Laila Woc-Colburn. I'm in the Division of Infectious Disease at Emory University in Atlanta, Georgia, in the United States. And I'm going to talk to you about a growing problem and that is not new. And you would ask, why do we have to talk about this in anesthesia and critical care? And the reason is that we are going to see patients who are septics or the use of antibiotics that are not indicated. And these are the patients we'll be seeing in our consults or in the hospital. In antimicrobial resistance, we can divide up in gram negatives as well as gram positives. And I'm going to talk to you more about gram negative because this is the growing threat that we have in the world. I have no disclosures. So our objective of this talk this morning is to describe the epidemiology of multi-drug resistant Enterobacterales. And I want to make an emphasis here because we used to know them as Enterobacteriaceae, but the nomenclature has changed. That is something that is happening a lot in microbiology with new names. There's some bacteria that we used to know them as Enterobacters have been shifted to Klebsiella, but this whole group is called Enterobacterales. Identify potential mechanisms of resistance by phenotypic susceptibility data, and describe an approach to the management of infections caused by MDR Enterobacterales, and I'll do this by a couple of cases. So how badly is this problem around the world? And it's very prevalent. By 2050, it's estimated that at least in the African continent, 4.1 million people would have died of antimicrobial resistant sepsis or infections, either because there is no antibiotics, because delay of care compared to other places where we see in the American continent, we have about 750,000. So it is a growing problem that it has come into the light of the World Health Organization as well as other organizations in Europe and North America. So the World Health Organization has some priority pathogens, and it has identified as priority pathogens Acinetobacter baumannii, which is something that plagues most of our IC intensive care units. One, because it is hard to get rid of. It can spread very quickly, and as a part of an epidemiology, can cause outbreaks in your ICUs. And you're seeing that we have carbapenem resistance. And then we have Pseudomonas that is also carbapenem resistant, meaning meropenem, doripenem, imipenem cannot do anything. And then the one that we're focusing are the Enterobacterales, which are surging throughout the world. One is probably the most common one, which is the extended spectrum beta-lactamase or ESPLs. And then what we'll talk about is the carbapenem resistance or CRE versus the carbapenem producing, which is CPE bacteria. So let's talk about ESBLs. So in order to understand ESBL, let's kind of have a understanding what is an extended beta-lactamase. It's something that we hear more commonly now. This usually means that you're going to have resistance to a third-generation cephalosporin. So even though your susceptibility pattern, your antibiogram may say that is susceptible, you'll see that there is a couple of clues that will tell you that using that will just enable the bacteria to turn on its gene and become an ESBL. It's resistant to monobactams like Astronem, and cephamycins like cefoxitin and cefotetan. Cefoxitin and cefotetan were used previously as prophylaxis, perioperative prophylaxis for colon surgeries. And this is important because the cefoxitin, when it's resistant, will have what we call an AMP-C producer. And having an AMP-C producer is something that gets turned on when you're given antibiotic like ceftriaxone. And a beta-lactam inhibitor is going to be susceptible to clavulanic acid and sulbactam. They usually are going to be part of enzymes, and the most famous ones are CTX and TEM and SHEBs. These are point mutations that you're going to have, the CTX and the TEM. TEM was named after the first patient that was seen in the 1960s, and this was a patient in Greece. And then CTX refers to the different third generation mutations that there is. We usually encounter this with two special bacteria, E. coli and Klebsiella. And the other thing is to know that you can either have a genetic predisposition like the AMP-C, or it could be a plasmid encoded. And realize that bacteria like to share, and plasmid is the way of sharing data from one person, from one bacteria to another bacteria. So let's look at the situation around the world. So the CDC are here in the United States has made Enterobacterialis a threat. We spent about $1.2 billion on the cost, either in hospitalizations, in treatment, and it's estimated, and this is data from 2017, that there were about 9,100 deaths. If you look at it, it has increased. There has been an increase about 53% throughout the years. And so this is what is very worrisome overall. Then let's look at how the interaction, the One Health concept that we call. So in the map that you see on your left of the screen, you see the geographical distribution of ESBLs in humans, animals, hospital, and community. And this is the Middle East. And you can see that there is an interaction between everything. So we know that the animal industry, the husbandry, in order to take care of the different animals, use antibiotics in order to make them more, produce more meat, to be better. But it's not just in the animals. We also see in the agricultural part, and it's not part of this talk, but we're seeing quite a bit of resistance to azoles like fluconazole and voriconazole because of the type of insecticides and pesticides used in the agriculture. Then you acquire it in the hospital because of an overuse of antibiotics, but also in the community because you can have an accessibility to antibiotics very easily with different types of brands that might have not had the right quality or even some contraband. That actually what pushes the resistance around the world. And then when you sample the water around, we find that the water already has some of these resistant bacteria coming from runoffs. So when we look at the problem, we have to see it as an integral part that is not just stop our prescriptions or better prescribe antibiotics in our humans, but also how to involve the community in the agriculture and the environment. And that's part of it. So when I say this is the ESBL production of E. coli, this is 2014 data. You can see the orange is about 25 to 50%. You can see that Egypt has quite a bit, as well as the Mediterranean. And this is part also on it was on a travel article, because they were testing travelers coming from these areas. They looked at their stools the 2 weeks after, 4 weeks after, 2 months and 6 months, and you could remain with this ESBL bacteria an average of 2 months. So that way is how the bacteria go from one place to another. And then you can look at the prevalence and molecular characteristics, and this is something that was reported last year on antimicrobial resistance and infection control. And this was a study done here in Egypt on using a urinary tract infections, looking at the prevalence of ESBL-MC. As you can see, E. coli and Klebsiella were the predominant factors, as well as Citrobacters, bacteria that we usually find in urinary tract infections. But you could see that AMC producers were mostly in the Enterobacterales. So E. coli, Klebsiella, Citrobacter, Enterobacter, ranging from 76 to 100%, meaning if we use something like a cephalosporin or we use a beta-lactam, it would have not worked, or commonly done ceftriaxone. You could also see that there were resistance a little bit to gentamicin, which is another, it's easily affordable, and you can do it intramuscular, but you already see quite a bit of resistance. So the study showed the prevalence of ESPL in Enterobacterales spread in South Egypt is alarming, and is what we've seen around the world. So our first case is a 30-year-old man with primary sclerosing cholangitis who has had 2 episodes of cholangitis over the past year, managed with antibiotics and endoscopic intervention. And he comes to your emergency department with a fever of 39 degrees and chills. The white count is about 14,000 and the total bill is 5.2. So, you have a patient that is suffering cholangitis, probably again another obstruction. Some clues that gives you here, he's been managed with antibiotic repeatedly over the past year. So you're already thinking that there might be some resistance going on. And you get blood cultures, and this is what they grow from the blood cultures. So it's a Klebsiella pneumonia, and what you have is that you have ceftazidime and ceftriaxone resistance, and you have meropenem and piperacillin tazobactam. So the question is, how will you treat this patient? So will you use meropenem versus piperacillin tazobactam? Obviously, even though it says ceftriaxone resistant, you are not going to be able. It could have say some, for example, ceftriaxone resistant, cefepime susceptible, and then it would depend on the MIC, so the minimal inhibitory concentration. If it's less than 2, maybe you can use cefepime at 2 grams Q8 to overcome that ESBL producing bacteria. But let's focus on meropenem and piperacillin tazobactam, because it brings you to an important trial called the Merino trial. And the Merino trial looked at this question: should we use piperacillin tazobactam, even though it says it's susceptible, and to spare the meropenem so we don't produce carbapenem? So they look at 379 patients with ceftriaxone-resistant E. coli and Klebsiella. The primary endpoint was a 30-day cause mortality. And what you find out, as you can see in the graph here, is that the orange line is piperacillin tazobactam, had a higher mortality at 12.3%, and meropenem had a mortality of 3.7%. So obviously you will say, well, yeah, but shouldn't there be something else? Why is there this discrepancy with the piperacillin tazobactam? Is there anything else going on? Because the number was a little bit too high. So they did a post hoc analysis, and they looked at 320 isolates. And interestingly, there was a discordance with the susceptibilities. There was a discordance between the U-class CLS breakpoint and the ATU. And the breakpoint for UCAS was 32, while the other one was 16, and the other one was 8. So that meant that if it was below that, it was not an ESBL. So they excluded these resistant isolates, and so they looked at the mortality went from 12% to 5%, but still meropenem was 3%. It was better. So the conclusion is that in these types of patients, the best part is to use meropenem. So if you have a Klebsiella pneumonia that has this pattern where you see ceftazidime and ceftriaxone resistance, your drug of choice is going to be meropenem and not piperacillin tazobactam. And this is very important because we're seeing more and more failure with piperacillin tazobactam. We are also seeing, especially in combination with vancomycin, more acute kidney injury. And it seems that there is a mechanism on the nephrons, and this has been explained by nephrologists. Okay. So the treatment options are going to depend on the site of infection. So the Infectious Disease Society of America has come up with guidance of how to do this. And we have classified it between two parts. This was just published about less than a year ago in September. So we classify them if they are caused by urinary tract infections, so they're in the urinary tract, or outside the urinary tract. So they made it simple. If it's a cystitis, no involvement and no bacteremia, and you treat for a very short period of time. So we're also treating less is better, more is not better. So less is better. So if it's a cystitis, you're going to treat it for 3 days using nitrofurantoin or trimethoprim sulfa according to your susceptibilities in your country. If a pyelonephritis or catheter-associated UTI, then you're actually going to go with the heavy guns and start doing more the carbapenems. Majority of the isolates in the area of the Mediterranean are already resistant to the quinolones, so you probably will end up using a carbapenem. And infections outside, you will end up using a carbapenem throughout. So it is a matter of how you do it. And then the other question is, can you do step-down therapy? Meaning, can you, instead of using IVs, can you do oral? So first you have to look at the susceptibility. So if it's susceptible to a quinolone, even though it has bacteremia, you can probably do it. Pyelonephritis, instead of being treated for 14 days, now are being treated 7 to 10 days if there's source controls and there are no abscess. So you're seeing that the treatments are going to be shorter and shorter, and this is to avoid resistance. The other part, if you have a pyelo and, for example, you have a stone or you have hydronephrosis, you have to relieve source control. Source control is the #1 thing. Without source control, antibiotics will not work, and it only leads towards more resistance. Another reason to do step down on oral if febrile hemodynamically is stable, source control, as I said, and no concerns of intestinal absorption. So if someone has a short gut syndrome, oral antibiotics probably are not the best option to go through. So in summary, ESPLs are heterogeneous. As you can see, they have phenotypical resistance to third-generation cephalosporins like ceftriaxones, and carbapenems are considered the first-line therapy for bacteremias. So moving on from there, we'll look at the carbapenem-resistant bacteria. The isolates, what we have to understand is that resistant is not the same as carbapenemase production. Isolates are usually resistant to IMI, penem, marrow, dori, or urta, and or documented carbapenems production. And this has to be documented in a lab that actually does testing for this. So if we look at throughout the world, this is our biggest threat, is the carbapenemase producing Enterobacterialis. And the reason is the greatest threat is because we don't have antibiotics. They cause the highest mortality throughout. The most famous is KPC, and that's for Klebsiella pneumonia carbapenemase. But the other ones that are coming up, which are the ones that worry about, is the metallo-beta-lactamases. New Delhi was the most famous one, and you can see it here in purple. Vim, which is one from Brazil, and IMP, they also consider part of that. And then we have the OXA40 likes, which are usually more confirmed to Acinetobacter and Pseudomonas. But as you can see, the Mediterranean world has quite a bit of predominant endemic area of carbapenemase. That's the red and the darker red part around. Antibiotic resistant in Klebsiella, you can see that if you look at the kind of hashtag part where Egypt is, and this is on a study done on hematological malignancies, there's been significant outbreaks of carbapenemase and enzymes, and you're surrounded by areas that you have endemic situations. this study looked at basically hematological malignancy patients where they had isolated them from bacteremias due to the immunosuppression under catheters, and trying to come up with a possible plan on how to avoid more and more resistance throughout. The most common one found in Egypt was the New Delhi strain. And then we look at this. This is from the resistance map of the CDEP, where we see the antibiotic resistance of Klebsiella carbopytamine resistance. And this just looks at the different trends. And you can see, for example, how, how bad it is throughout the world. And if we look in Egypt, the data from that same place where it captures data given by the Ministries of Health, you can see that the blue line, or the light blue line, which is carbapenems, have had increase throughout, while the fluoroquinolones have remained at 75%. But as we say, we worry about the carbapenems because we don't have a lot of options after that. So let's look at a case. Same man, 30-year-old man with primary sclerosis and cholangitis, had 2 episodes over the past year, managed with antibiotics, endoscopic intervention, presents 39 degrees, white count of 14,000, admitted for management of cholangitis, but now the blood cultures show a different pattern. So now you have something that it basically says that you only have aminoglucoside susceptible. And what calls your attention is that you have this meropenem resistance. So the question is, what do? Do you ask for more susceptibility? How are you going to treat this patient? He's bacteremic, and we know that aminoglucosides are not good for bacteremia. So what are we going to do? So the older regimens were things that, we became very creative. The reason that we became creative was because we didn't have antibiotics. And so, for example, we would use a carbapenem on a high dose extended infusion. So we do like 2 grams over 8 hours. So you cover 24 hours. You kept those concentrations above the MIC, or the area under the curve, and you use polymyxin or colistin. Then, if that didn't work, you would add tegacycline, hoping to have different mechanism. You would do the Trojan horse with a double carbapenem. That means that you would give the patient ertapenem, maximize the carbapenemase producing part, and use the meropenem or imipenem to go around it. So that's what we call the Trojan horse. Fosfamycin IV, it is not available in the United States, but available everywhere. And then combinations. So for example, with Acinetobacter, we will use rifampin and aminoglucosides. And we now know that the rifampin, really adjunctive therapy, doesn't really work that much. But we're in 2021, so we do have some new novel agents coming up, which already have acquired resistance, which is bad. Ceftazidime, avibactam, merobactam, barbobactam, imipenem, relebactam, cefdirichol, which is kind of the new kid on the block, as well as everacycline and plasmomycin. So we still have our patients. What are we going to do? So we can look at this, and we classify it as a 2nd generation beta-lactam, beta-lactamase inhibitors. So we have this is from a collaboration from Dr. Pouch, who is a colleague of mine here at Emory, where she had looked at ceftazidime, avibactam, is very good for ESBLs, KPCs, and OXA, but not for metallo-beta-lactamases. So if you have the New Delhi, IMPs, VIMs, and things, not good at all. Very good for KPCs. Higher MICs with KPC3, there's some reported resistance, and there is failure with pneumonia, cited as factors, clinical failure, pneumonia, and renal. Meropenem, barbobactam, which is kind of imipenem, relebactam, which came out in the last 2 years, again, very good with ESBLs and KPCs. No activity against metallo-beta-lactamase. And as you're seeing, the metallo-beta-lactamase is what is causing us. If you have had meropenem, barbobactam, or relebactam, it will cause a porin mutation that will make it inactive. So you ask, what about the metallo-beta-lactamases? What are we going to do about this? So we do combination therapy. So we can do ceftazidime, avibactam plus astronam. There's one now combination coming up with this combo, so it's a one. There's no resistance to astronam, remains stable against metallo-beta-lactamase. We've had very good activity. It has other expression of cephalosporins, ESPLs, usually overcomes. It has seen to be a really good working horse so far. But I've mentioned some novel agents before, and these are the ones that we're using if we don't have available the safety avibactam astronam combination. So the ceftiricol is interesting because this is the first antibiotic that acts on the iron. So acidospore, cephalosporin. So it comes through the iron pore that has the bacteria, has very good activity against ESBLs, KPCs, metallo-beta-lactamases, and OXA48. It's been approved for, for catheter-associated UTI, part of the credible clinical trial. This is an antibiotic I have used for lung transplant patients who are cystic fibrosis and come with Achromobacter and Pseudomonas that are metallo-beta-lactamases. You can give it on a standard infusion. Caveat is that you can have some hepatitis, so increased LFTs, as well as pancytopenia. Evercycline, so a tetracycline, similar to tigacycline, doxycycline, minocycline, but this would be like fourth generation. It's a fluorocycline. It's very good against ESBL. Another thing that evercycline is very good is against your non-tuberculosis mycobacteria. Plasmomycin has been approved for catheter-associated UTI. This is an aminoglucoside. It does have reduced activity against the New Delhi activity. So this would not be something that you would like to use in Egypt because you have predominant New Delhi strains. So these are the three that have come up. Not very encouraging, but at least we have a little bit more weaponry in our arsenal. So if we summarize, so you have carbapenem resistant Enterobacterialis outside the urinary tract, and the mechanism of resistance is unknown. Your first one is to go with ceftazidime, avibactam, or meropenem, varibactam. If you know you have a KPC, then you do ceftazidime, avibactam, meropenem, varibactam. If you have a metallobectamase, you do cefti, avi, plus astronam, or you get ceftiricol. If you have OXA48-like identified, ceftaz, avibactam. And then if you have urinary tract infections, again, we can do the pilo-cefti avibactam for that, especially for pyelonephritis. We can use, since if you don't have bacteremia, we can do high-dose aminoglycosides. It concentrates really well in the kidney. It's not going to cause kidney failure, but it actually overcomes resistance and clears the pathway. So in summary, infections due to multi-drug resistance Enterobacterialis continue to pose a significant global public health. We need early target treatment aids improving patient outcomes. You really want to have good antimicrobial stewardship doing the One Health concept, because if we can avoid the resistance, then we won't end up having the MDRs. And with that, I thank you. And this is a picture from one of the volcanoes in my home country in Guatemala. Thank you.
Thank you, Dr. Colburn, for this nice presentation. Is there anyone having questions? We don't have any questions. So what you do in the patient who has resistance to all the drugs, to all the antibiotics, have you faced any?
Yes, we have. I mean, that's the nightmare of all infectious diseases. We end up trying to come up with combination therapies. There are some clinical trials for other drugs that have not been, haven't been approved. And the other part is looking at source control. But when you face that, you have a very strong talk with the family, because, if it's they're in the intensive care unit already with 3 or 4 pressors, there's nothing we're going to be able to do to change that outcome at that time.
Thank you. Okay,